So hi, good morning, everybody. So this is new for me on the outside because of a traffic jam, I couldn't make it in time. So I hope everybody can hear me. Today is a very exciting Journal Club day because two papers will be presented and discussed that are very close to my heart. And I'm very proud that they both will be presented by two former PhD students of mine. And the topic is about oxygenation sensitive MR. And I think we will start with, and both know the Journal Club, so we will not go through the rules. So Katie, if you would take it from here and share your screen, and we'll first hear about a paper from the team at the Inselspital. And it's a very exciting study, but I don't want to steal any thunder. So Katie, if you could take it from here and present this fantastic paper.
Okay, thanks. Everyone can see the PDF, okay?
Yes, looks great.
So this is one of our key studies we've been running here in Bern in Switzerland. So if you notice, we're the Department of Anesthesiology and Pain Medicine. And MRI isn't often used in anesthesia. If anything, it's echo. So most cardiovascular anesthetists are all certified in transesophageal echo, but you really don't see MRI studies. Why it's interesting to implement MRIs, because it's kind of funny, but anesthesia is the field in which most things were discovered by self-experimentation by anesthetists back in the day. So actually many medications and protocols have been used for over 100 years and still little is known how they actually work. And so this is what we wanted to do, is we wanted to actually look at induction of anesthesia in humans and patients using MRI. And so, I mean, this is a CMR group. We know that most times during diagnostic imaging, we're looking for ischemic heart disease or other comorbidities. But also what most people don't realize is that infarcts actually happen quite a lot during surgery. This is because, of course, as the population gets older, they all have heart disease, which you guys know, but these people are even going for surgeries that are non-cardiac surgeries, such as hip replacements, knee replacements. And oxygen supply mismatch is one of the main types of MINS or mix, which we call, so that's myocardial ischemia during non-cardiac or cardiac surgery. And so this is a very large topic of interest in anesthesia. And right now it's measured by troponins, but troponins indicate cell death, and we actually don't know what happens with troponins till 24 and 72 hours later, which is the guidelines actually. And then you, of course, don't know what caused the ischemia when you're measuring troponins. You just know it happened at one point within the last day or two. So using oxygenation sensitive imaging, it's a technique that can actually measure the difference in the supply-demand imbalance. And our physicists here have been working to develop a free breathing technique so we can apply it continuously during oxygenation. So we have a study here that we're running, and we recruit healthy patients, heart-healthy patients. So these are patients under the age of 45. They're undergoing orthopedic surgeries. I say this is in Switzerland, so half the time it's orthopedic surgery to repair damage from ski injuries. But anyway, they have healthy hearts, and they're coming for scheduled general anesthesia. The other cohort is patients with defined coronary artery disease, and they're coming for either mid-cab or CABG, so some sort of cardiovascular surgery, not valve surgery, with anesthesia as well. And then what they do is they just come to the MRI, we do some baseline imaging, and then we start this free breathing oxygenation sensitive sequence, and we start the entire anesthesia induction protocol. So the first part of the induction is paced breathing. So this is a few minutes of paced breathing, about 14 breaths per minute, followed by 5 deep breaths while they're breathing oxygen. So this is pretty standard. And so what we see here, this is a healthy control. We can see that this paced breathing, first of all, reduces carbon dioxide, which we're measuring through the mask. I think it went from about 30 millimeter mercury down to about 20 in this patient. So they're becoming quite hypocapnic. This is, of course, basically just normal breathing. They've been given no medication at this point, except for oxygen. We have an increase in heart rate. So this is basically what we've seen in the diagnostic papers ahead of time. And this reduces oxygenation and increases myocardial strain. So yeah, but the previous papers have shown in awake humans. Then what an anesthesia protocol involve is the administration of fentanyl. This is an opioid, but it actually does cause most people to slow their breathing quite a bit. And we can see here that CO2 rises quite a lot in this patient, up to almost 40 millimeter mercury. And this caused a significant increase in the myocardial oxygenation. And then with this patient, we get propofol and rocuronium, so that'll fully stop the breathing. And in this patient, what we normally do is we start a mask breathing, so with a manual bag ventilation. But due to the position and a bit of obesity, the starting of the mask ventilation took maybe 20 seconds longer. So it means they had an extended breath hold. So this is actually pretty normal in anesthesia. But then what we can see here is a rapid increase of oxygenation. And we see it's pretty homogeneous across the myocardium too. And then what's interesting is once you put these patients on mechanical ventilation, so this is where they're breathing against end expiratory pressure, we have a general decrease in oxygenation for about 8 minutes. And we've done now 6 of these control groups, so it's not in this paper. And we generally have this, 6 to 8 minutes of myocardial deoxygenation occurring before they normalize, whereas strain just remains reduced. And this is actually kind of known as well in anesthesia about strain, where we have the cardiac depression effects of anesthetics. So strain is reduced, blood pressure is reduced, and everything is reduced. So this is kind of the first time we've actually been able to see what's happening to the heart on almost a per second measurement, temporal resolution for oxygenation and strain. And then of course, we actually want to see, so just final points on this healthy person, as you can see that most times the oxygenation and strain are increasing and decreasing all within a 10-minute period. So if this is a young healthy control, what of course happens to the cardiovascular patients? So this is our cardiovascular patient. The extra data is in the supplement, but he had already had CT, angio, went to the cath lab, had FFR done. So he had a single vessel disease, but multiple lesions in the LAD, fractional flow reserve, trying to remember, about 0.7. And he also had a coronary anomaly. So this meant the LAD actually perfused a much larger territory of the heart, the anterior wall and the septum. And so what you see here is with the spontaneous breathing, we have actually the exact same effects. We have a decrease in oxygenation, a decrease in end-tidal CO2, not as large a change in the heart rate. And I should say, I think this patient was only 52 and actually somewhat healthy. Always a hiker, always a climber, but a family history of coronary artery disease. And no previous infarct. This was a diagnostic exam that actually led to the follow-up and the surgery. And he was scheduled for mid-cap because he was actually so young, so they wanted to just replace the entire vessel. And then what happens is he slows his breathing and his oxygenation returns to normal. Then he's put on the manual bag ventilation. So again, this is anaesthesia, they're bagging the patient, and that's actually basically hyperventilation. And you can see again, the CO2 dropped quite a bit, almost, I think about 19 millimeter mercury in this patient. And then again, we have a normalization of the oxygenation after intubation, which is another breath hold. And then what we see here is once we're on the ventilator, we have, unlike the healthy control, we have a regional variation in the myocardium. So where the post-stenotic territory remains, had the lowest oxygenation for a long period of time. And we also see this cause quite a large strain deficit, where strain dropped to almost minus 5% from minus 19% to baseline. So just within a short period of time, this patient, who was actually considered somewhat low risk, although still heart disease, had regional variation induced in the oxygenation and the strain, which we said could be indicative of the inducible ischemia when we see oxygenation deficits and strain, systolic strain and diastolic strain dysfunction occurring in the same myocardial tissue. So this is some of our first results. It's actually quite interesting to see, first of all, what's happening with the induction anesthesia. I think we're one of the few groups actually performing anesthesia, inducing anesthesia within an MRI, which is unique. And we will keep continuing this with other measurements as well in the MRI. And then this data can be found in the British Journal of Anesthesia, which is actually one of our top art journals for our fields. And any questions?
Yeah, thank you very much. It was fantastic. And I think this is really a very exciting paper. And as you said, it's the first where you really we could really watch physiology happen while patients are being scanned. So congratulations to that study. If there are any questions, just speak up or write them in the meeting chat. So from my point of view, so the question I have is, Katie, you have a lot of experience with oxygenation sensitive MR. So using your recent findings and your experience you had now, where do you think, or what are the most promising biomarkers that we can derive from the oxygenation sensitive MR? What do you think are the most important limitations of this technology?
Yeah, so for us, because of course we're more anesthesia, so we're not using it so much diagnostically. I think what you guys are more looking to, if you want to use into diagnostic, you need to make fast ways to see this, either inline in the scanner or quite simple when you're analyzing. And for us, we like to have multiple markers indicative of ischemia. That's why we like the oxygenation, which if you follow the ischemic cascade is one of the first steps of ischemia. And we also like to combine it with the cine. So we have the systolic and the diastolic dysfunction as well. So we can really see if these deoxygenation events or regions are actually translating to any functional problems or if there's any relevance to this deoxygenation.
Okay. And when you look at your patients in Bern, did you have any people who had problems with the protocol, holding their breath, or with understanding the breathing maneuver, if at all? So not, of course, it's not necessarily the anesthetized patients, but in general. So what is your experience with the feasibility in patients, especially with a disease such as heart failure?
So first I'll say this anesthetized cohort's my favorite because they're awake for 5 minutes and then they're on the ventilator and they're very compliant once they're anesthetized. So they're my favorite cohort. Once you start going into the other breathing maneuver techniques, it always depends on the population, I've noticed. So of course, anyone recruited for a research study has willingly accepted to come in a research study. So they're normally pretty applicable to doing everything. Otherwise, we put this in a few hundred clinical patients as well. And I know for the most part, probably get 90–95% compliance. So I see it's no worse than when we give adenosine or regadenoson, where patients normally are unhappy with making any breath hold during stress. But again, it's something you're still reliant on participants to perform. Yeah. But here, for the anesthesia study, when they're doing the free breathing, they also are listening to a metronome, and they have 3 anesthetists in the room with them, guiding them what to do as well during the study. But the very nice thing about the free breathing sequence we're applying in this technique is we can basically image the whole time, and then we can look at our data afterwards to see where we need to assess certain steps. We're not like compliant on the patient performing the breathing maneuvers exactly when we're imaging.
Okay. So there's a question. Yeah.
I was just reading in the chat a question from Mitchell.
Yeah, exactly. Yeah.
Yeah. So how do we keep image quality during breathing? Is so in this study specifically, we've gone away from the segmented cine, and our physicists have basically made us a real-time cine. So it's not the compressed sensing specific sequence you might be using now with the newer scanners. So we do have this for our functional analysis, but it's basically a 1 cardiac cycle per heartbeat component. So we're not reliant on any registration over breath holds, over ECG changes or anything.
Okay. Thank you very much. Another one, do you have PK/PD data? Is that proton density, or I don't know whether Dr. Khalili Mahani, whether you could speak up to explain what you mean by that? At least I don't know.
Oh, yes. Hi, sorry. The great work, Katie. Thanks. I was wondering if the drug dosage was, if you have data on the drug administration per person. So it's a pharmacokinetic, pharmacodynamic, the PK/PD.
Okay, yeah. So, I mean, of course, these are full-on surgery patients, so every single agent that's given to the patients is monitored. For the most point, like we haven't done stats with this yet, but we have a pretty standard regimen for the patients. It changes a bit on weight, and until after induction, none of these patients need any catecholamines or any vasopressors. But otherwise, in the case reports, the drugs that are provided are just listed, but we haven't done any stats with these yet to see exactly if it's dose dependent on the sufentanil, weight dependent, or what happens with this.
Right. And the other question might be relevant. So all of these are on some, like all of these anesthesias are done with an opioid-based drug. Might you have anything involving ketamine, perchance?
So yeah, all anesthesia protocols vary a little bit. With the adults, I mean, I'm not the anesthetist here. We don't use ketamine as often in our cohort. So right now, to keep it consistent, because it's such a small sample size, we're just using basically a sufentanil propofol rocuronium-based protocol. Also not a gas-based induction. And ketamine's a bit more used in the children here. So we, of course, don't use those in our MRI either. But eventually, once we get this going, it would be interesting to see how the different anesthetics impact the heart based on the workload and the blood pressure effects.
Yeah, thanks. Thank you.
Okay. Thank you very much. So I would like to now move on to the next paper. It's so state that up front as a conflict of interest. It's from our team here, and it's Liz Hillier, first author of the study, which was released yesterday, the press embargo on this paper. And it's a study on the link between heart failure and cognitive dysfunction, and also using oxygenation-sensitive MR. So Liz, take it from here, and thank you very much.
Thanks, Matthias. Can everyone see my screen?
Yes, I think
the paper
can see it.
Fantastic. Okay, I just want to thank you for inviting me to speak here. I know that you're involved in the project, so we're both pretty excited about this finally being out there. But also I want to thank Katie. I mean, she was also involved in this project. She's one of the co-authors and was my mentor very early on with OS. So it's nice to be able to present here in the same kind of venue as her. But basically, as Matthias mentioned, our study is titled Microvascular Dysfunction as a Possible Link Between Heart Failure and Cognitive Dysfunction. So what we wanted to do was look at patients with heart failure. So we have all kind of three types of heart failure. So we have reduced ejection fraction, preserved, and mid-range in this study. And we wanted to look at the association with cognitive dysfunction, but also look at oxygenation sensitive MRI signal intensity in two vascular beds. So we looked at the heart and the brain in this study as well. And this was the study that my PhD was largely founded on. As we all know, heart failure, very popular, kind of significant global health burden here. And the underlying physiology of heart failure is heterogeneous, as I mentioned. There's different ones. It's incompletely understood. There's probably many overlapping pathophysiologic mechanisms that are going on and probably different for all different types of heart failure. But one of the things is this heart failure-associated development of cognitive impairment. And there's different proposed underlying etiologies for this. One being chronic cerebral hypoperfusion or decreased cerebrovascular reactivity, and that can be through endothelial dysfunction, kind of as one of those proposed mechanisms. So obviously with the oxygenation sensitive cardiac MRI and our vasoactive breathing maneuvers, we're thinking that we can assess kind of endothelial dysfunction, that endothelial dependent pathway in terms of kind of vasomotion. And so that's why we employed oxygenation sensitive cardiac MRI and in the brain as well in this study. So we looked at, we ran kind of a standard protocol. So we have function kind of standard morphologic parameters with our cardiac MRI as well. We also looked at T1 and T2 mapping. So we were able to get some tissue characteristics for these patients as well. We compared patients, heart failure patients, to normal controls. And as I mentioned before, in disease states, you kind of are looking for this impaired vascular endothelial function. And so the hypothesis was that you would see this in heart failure. And Katie's published on that before, that you do see a reduced global breathing-induced myocardial oxygenation in heart failure patients. So that was one of the hypotheses here. And essentially, this study aimed to assess the myocardial and cerebral oxygenation status in patients with heart failure, and to correlate these findings to the cardiac and cognitive functional status. So 20 patients and 23 healthy controls were included in the study initially. The inclusion criteria for patients was an age greater than 50 years of age, one presenting symptom of heart failure at clinic presentation or hospitalization for heart failure, or regularly followed up in the heart failure clinic at the McGill University Health Center. Or also the New York Heart Association functional class 2 or 3 at the time of study enrollment. Patients were excluded if they had a recent MI, also if they had a recent stroke or kind of vascular event. And we kind of recruited consecutive patients that were screened from our heart failure clinic, echo clinic, or patients who were scheduled for a regular clinical MRI with us for an indication around heart failure. As I mentioned, we also compared these to healthy volunteers, and our exclusion criteria was pretty standard, kind of no history of cardiovascular, neurologic, or pulmonary disease. To assess cognitive status, we used the Montreal Cognitive Assessment test with a score of less than 26, indicating cognitive impairment. And there's been studies done with the MoCA to show that it's probably actually pretty sensitive to detect mild cognitive impairment, especially cognitive impairment from like a vascular cause. So we ran our heart MRI, our standard OS CMR protocol with the vasoactive breathing maneuver, so period of free breathing, then paced hyperventilation with a metronome for 60 seconds, and then a voluntary maximal breath hold, so as long as they can, with a minimum of around 20 to 30 seconds to be included for analysis. For our brain MRI, we used a blood oxygen level dependent sequence, so a BOLD sequence, and that has been published previously in terms of the BOLD sequence parameters. Instead of just one vasoactive breathing maneuver, we actually ran 3 consecutive breathing maneuvers. So the period of hyperventilation, breath hold, and then we had a 90-second period of normal breathing to allow kind of the physiology to return to baseline. And so as I mentioned, when we talk about the BMOR, the breathing-induced myocardial oxygenation reserve, as I'm sure you guys have heard us talk, or hopefully heard us talk about this before, we compare the 30-second time point of breath hold to 0-second time point. We take a percent change and we call that the BMOR. So that's in the heart. In the brain, we did very much the same thing, and we called it the B-core, so the breathing-induced cerebral oxygenation reserve. And we took an average of the B-core for each of those 3 consecutive breathing maneuvers to control for kind of more noise that's present in the brain and the smaller signal intensity changes. We ran traditional statistics on this, and then we also ran univariate linear and stepwise multivariable linear regression analyses just to look at associations between some of the parameters with the BMOR and B-core, as well as to assess the variables that best predict the change in BMOR and B-core in heart failure patients. Some of our results, so we included 20 patients with heart failure and 21 healthy controls. In the end of the patients with heart failure, as I mentioned, we kind of had a mixed group. So 10 had reduced ejection fraction, 2 had mid-range, and 8 had preserved. On average, patients were older than our healthy controls and had higher body mass indices. And just in terms of functional parameters, patients with heart failure had a lower left ventricular ejection fraction overall when we kind of group the cohort. They also had lower MoCA scores. So as I mentioned, less than 26 indicates mild cognitive impairment. So the mean for our heart failure group was 23. We also found that patients had larger volumes, so both end diastolic and end systolic when compared to our healthy controls. Interestingly, our patient group also had higher myocardial T1 and T2 values, but when you look at kind of our local reference standards, they weren't clinically significant. And then getting into the meat of this, really, with the tissue oxygenation response, on average, the B-core and BMOR were lower in patients with heart failure when compared to healthy controls in both vascular beds, so in both the heart and the brain. There was moderate correlations between the B core and B more, and there's a figure here too. So when we look at the B more, so the myocardial oxygenation reserve in healthy compared to heart failure, there's a significant difference between the two groups. Same thing when you look in the brain with the cerebral oxygenation reserve. And when we look at the correlation between the B more and the B core in healthy participants, there's not really any meaningful correlation. But when we look at our heart failure patients, there is this positive correlation. That's pretty moderate, I would say, in terms of the correlation between those two things. In terms of cognitive dysfunction, the MoCA score in patients with heart failure was moderately correlated to a number of parameters, including the B more. In the 10 patients that we had that had reduced ejection fraction, there was a high positive correlation between the more and the MoCA score, but it was not, the MoCA score was not correlated to left ventricular ejection fraction, interestingly. When we look at the factors contributing to the B core and B more and the changes in what's associated together, disease status, so presence of heart failure, the use of beta blockers, and diastolic volume and cardiac output were associated with a B core. And then when we ran the stepwise multivariable regression, the presence of heart failure and cardiac output were the best predictors for B core. And interestingly, they're not ejection fraction as well. When we looked at the same thing for B more, when we used the multivariate regression, the presence of heart failure again, and in this time end diastolic volume was the best predictors of the B more. So when we look at this other figure 2 here, this is talking what I just mentioned, the correlation between your MoCA score and the myocardial oxygenation reserve. So when we look over here on the right at our healthy controls in red, there's not really much of a correlation, as I mentioned, but when we look in blue at the patients, there is this nice positive correlation. And I just put up 2 examples here. So the perfect score is 30 in a MoCA. When we looked at a patient who had a MoCA score of 29, they had a nice green, mostly homogeneous, really good global B more response. And they had a left ventricular ejection fraction of 60%. When we compare that to somebody who had a MoCA score of 18, so indicating mild cognitive impairment, we can actually see here there's a globally reduced myocardial oxygenation reserve in this patient. They also had a left ventricular ejection fraction of 24%. So we can really see this on a level that the correlation between your kind of cognitive impairment and the global B more response there as well. So just kind of into the discussion a little bit. So in our study, we observed a reduced oxygenation reserve in both the heart and the brain, so myocardial and cerebral vascular beds, as I mentioned. That wasn't related to left ventricular ejection fraction, as we had initially thought. It was related to cardiac output. So, you know, this change in cardiac output is what's associated with the vascular dysfunction and cognitive impairment, and that's what we had found here. And we can see that in our figure here as well, very nicely. Myocardial dysfunction and heart failure was associated with, as I just mentioned, impaired cognitive status and impaired cerebral oxygenation reserve, reduced cardiac output, and an impaired breathing-induced myocardial oxygenation reserve, that all of these things were correlated with each other. And when we look here just at some examples, this is a healthy volunteer. We had nice global kind of changes in the brain, and this is a gray matter mask here, represented by green. And that same patient that I presented, or the same healthy volunteer that I presented earlier, with that kind of maintained or really good B more response in the heart. And when we look at a heart failure patient, we can see this reduced, more or less globally reduced B core, and we see that same globally reduced B more, as I showed before, in the heart of those patients. So when we look at a couple of other things, we also demonstrated, as I mentioned, lower cognitive assessment scores in patients with heart failure and an association between cognitive impairment and myocardial oxygenation deficits, highlighting a possible association of microvascular dysfunction in both the heart and the brain with cognitive impairment. There's a couple of limitations. I know, Matthias, I'm out of time. We have a small sample size with a cross-sectional design, so that was obviously a limitation here. We had a very strict inclusion criteria for both our patients and our healthy volunteers, so maybe not broadly applicable, but I think actually that our strict inclusion criteria also helped us because there was no macrovascular injury in these patients. So we can say that probably all of this is due to microvascular, or at least there was no known macrovascular events. So those were the kind of main findings for us. To summarize, that heart failure is an independent predictor of both coronary and cerebral microvascular dysfunction, as defined by a reduced response to vasodilatory breathing maneuvers, and that impaired response was associated with reduced cognitive function.
Yeah, very, very, very good. Thank you very much, Liz. So the obvious question here is, how much do you think this is an association? What is the causality chain here? You have thought about that and read about that a lot. Do you think that, and it's interesting that not the ejection fraction that is typically used to kind of describe quantitative heart failure, but that cardiac output was the more predictive marker. So do you think a low cardiac output then begets microvascular dysfunction, or do you think in the brain, or do you think that there may be an underlying process that causes then cognitive dysfunction and also comes as a bystander for heart failure? So what do you think?
I think it's probably a little bit of both, with just kind of a cop-out answer. I don't think we know enough, but I will say one of the things that I didn't touch on is one of the biggest predictors for BMOR and BCOR actually was systolic blood pressure. So I think that it's possibly twofold. When we watched it be related, or when we saw it be related to cardiac output, the obvious thing to think is, okay, if you have a reduced cardiac output, you can have some sort of chronic cerebral hypoperfusion that can lead to this in the brain. But when we look at the effects of blood pressure, it does raise this question of, if you have hypertension, and we know that affects the microvasculature, is that affecting it in both vascular beds kind of in parallel? And I think it's probably a combination of both, because we did see this reduced BCOR in HFpEF patients as well. So I think that there probably is multifactorial, and possibly if you have HFrEF, you're having a double hit as opposed to just kind of the hypertension leading to microvascular dysfunction.
Okay, thank you so much. There's one question. Is the MoCA administered or assessed before or after the scan, or another day? How was that done?
So the MoCA had to be done within 2 weeks of our scan. I don't think anyone had a MoCA done after the scan. Typically, it was an hour before the scan on the same day. We did it before we put them into the MRI scanner.
Okay, great. Fantastic. So if there are no other questions in the interest of time, I would like to hand over. So Liz, if you could unshare your screen, I would hand over to Nicole, who will talk about the next CMR Journal Club.
Yes. Hi, everybody. Hopefully you can see my screen now. So next month we're going back to the first Wednesday of the month again, after a couple of months where we've had to shift things around. So on November 1st, we're going to be looking at a couple of papers that discuss developments in low field CMR, partly as an opportunity to get ready for the ISMRM SCMR workshop on low field and high field imaging, which is happening right before the SCMR in January. So we have two papers. The first is preliminary experience of cardiac proton spectroscopy at 0.75 T, and that will be presented by Sebastian Kozerke. And then we have contrast optimal simultaneous multi-slice balance SSFP cine cardiac imaging at 0.55 T, which will be presented by Ye Tian. So we hope to see you guys all there.
Thank you very much, Nicole. So thanks everybody for joining, and I hope you enjoyed that. And I'm really looking also forward to the next one. I think low field is a very, very interesting spot to be now. And this may have significant clinical implications. So I'm looking forward to that. Thanks, Katie and Liz, for being available and for the wonderful presentation of this work, which, of course, I find very exciting. And so I wish everybody a good rest of the day and all the best, and until the next time. Bye-bye.